right, so we have a big task before us here because we end with a question at the heart of every health system, and that's how we build financial sustainability. Across Europe and beyond, systems face aging populations, staff shortages, rising costs from breakthrough medicines, and the ever-present risk of shocks from pandemics. Leaders are under pressure to manage today's crises while also planning for the next decade and beyond. So, Vytenis, I'd like to start with you because you've argued that health is not only about crisis management, but also as a foundation of economic growth and resilience. What role should prevention and a stronger European health union play in making healthcare financially sustainable?
It's for me.
For you.
Colleagues, may I raise one controversial answer in this question? Because we are all speaking about investment. My question is, are we capable to change old formula of GDP, which was done in 1970s, including human capital indexes into GDP? And then we will change immediately situation with calculations about investments. Because we are now also speaking about investments in human capital. What does it mean, healthcare system? Of course it is investment in human capital. But please discuss those issues with economic. They can tell you they are using very old formula. OECD based on old formula, World Bank on old formula, IMF on old, European Commission also do the same, and European Observatory sometimes is raising question. Look, are we capable to change something? Because we are speaking about investment, not calculating the human capital in GDP. And then you can have differences to compare. How can we move forward? And how can we defend our healthcare sector, one of the biggest sectors in the European Union, the biggest economic sector. But we are far from assessment of real situation. And I spent speaking about investment more than 20 years. I am tired. Because look, I took those three very important papers today. One is about bio. It is about personalized medicines. It requires investments. Look into such excellent report. Paying for medicines in evolving health systems, out-of-pocket problems, once again. And this one about prevention. I ask you very well, it's an excellent opportunity to discuss in reality why we are so blind. Only speaking about in very defensive mode. We need to be proactive. We need to be pro-offensive, speaking about prevention. Because we all know that prevention is better than cure, for sure. But when we asking ministers of finance, prime ministers, leaders, European Commission, nobody can tell you why we are so in a stupid situation. All knows that prevention is better, but no one is changing something. I am very young, and only 74, aging population. But how can we really say something on the ground that we now it's time to change situation, because it's really we will do the same 20 years in the future if we are not changing big grounds and defending investments, capacities, and calculations investment, including human capital. Sorry being so emotional.
Thank you. It's a great place to start, and you all have a tough act to follow. So I expect the same amount of emotion in this. So Paolo, I think there's some things to pick up on here, obviously, because your Horizon Europe Flash project looks at flexibility in health financing. But I think importantly, how can systems build in more adaptive funding across time, regions, and levels of care? And to this point, evolve the way we're thinking about investment.
Yeah, exactly. That is one example. So the starting point of what we are trying to do with this Horizon funded project is to understand flexibility in the system. So the motivation is essentially that the landscape is changing so rapidly but the financing systems tend to be very static in a sense, and in many dimensions, let's say. And can be one of the dimensions. It's not the main focus of our project, but of course it is crucial. So how much do we allocate? We don't necessarily need to focus on curing people, but there is an early stage where we can do even better, probably. We focus more on the other side, let's say, and there are several dimensions. So we flexibility, for example, with respect to sudden changes in health needs, as was the case with the COVID pandemic, but also with more structural changes like population aging and, let's say, long-term projections of what will be health expenditure and therefore how to react and actively work on that. But also flexibility on allocating resources to people who need care, essentially, both at the individual level, so the big topic of unmet needs, and in relation also to out-of-pocket payment, which may help sustainability in a sense, but on the other hand may reduce the social sustainability of the system and the ability to meet health ends. But also technological change in the sense that often technological innovation is perceived as a threat in a sense to sustainability, and therefore better tools must be developed to understand in advance what will happen and to really use these opportunities to make them become a value, not just a threat.
Definitely. Interesting. Okay, we'll come back to some of these things. Peter, I'm interested in your reaction to what's been said so far, but also from the private investment perspective, what kind of changes do we need to see to attract long-term capital into healthcare? And how can public-private collaborations ensure that innovations actually scale?
Good questions. And a big context on my side. So I spend my time investing in pharmaceuticals, drug development, pharma manufacturing, bit of medical devices, and a little bit of what I see day to day is huge amounts of innovation going into therapeutics, which is fantastic, and I think going to be a great thing for the world. You mentioned, Manon, at the beginning around like a decade-long decision-making. I actually think we have a century-long decision-making because we sit here today with 80% of diseases, like the mechanism of action of disease, not well understood. And you've got 95% of rare diseases out there without a cure, without a therapy for it. So the way I see things is like with all modern medicine, we're still only just like starting to kind of get to the tip of the iceberg of the potential of what we can do therapeutically. And there's so much money going into that from the private sector, into biotechs and into pharmaceuticals. Whilst that's all a fantastic thing, I don't think the healthcare systems in their current, status quo can absorb that much new therapies coming. The cost of the therapies, the fact that they're going to make people kind of live longer and then, be in the healthcare system for longer. I think there needs to be big changes in the way we operate healthcare as a system and how we provide healthcare, so that actually those things move in parallel. So therapeutics actually move with provision of care, and both of them can move forward. I think from an investment perspective into the healthcare system, people have to come with an efficiency lens. They need to find ways that we can do more with less. And I think today that is a lot of it around how can we get people treated more efficiently. So you mentioned preventative care. I think preventative care is a huge amount. And maybe, you're making some interesting points. Maybe there's ways governments can even get in there and influence. Like if they know that I'm being healthier and they know that as a result of me being healthier, I'm going to be a lower burden on the healthcare system, I should get a tax break. Come on. Like there may be some ways and incentives that actually there can be kind of a really holistic way to drive better behaviors in people day to day so that we are a lower burden to the system. But equally, the world spends so much money on therapeutics. And today, only 5% of the healthcare system is spent on diagnostics. Diagnostics determines 70% of healthcare decisions. And we've all had relatives out there and friends who have been in the healthcare system getting mistreated for many years until they eventually get on the right diagnostic and then the right therapy. They are very expensive to the healthcare system, and it's poor healthcare. So I think there's a huge investment that's needed into diagnostics. And I think diagnostics done efficiently drives huge value for the healthcare system and should get real big funding into it. And the final piece that should get a lot of big funding that drives efficiently the healthcare system is technology, which you mentioned, Paolo. And I think a big part of that is leveraging digital and AI. We are in a new age, and we heard the last panel around the amount of investment going into the US. There is a big investment going into AI for healthcare. Now, I think a lot of that right now is still inefficient. It's still kind of, working its way through to understand where it's most relevant. But I think that for the future of healthcare, some of the biggest costs in the system are people costs. Some of them are process costs. And by digitalizing and tech enabling people and processes, I think we can change the cost base of our healthcare system, which then allows room to grow with the therapeutics.
Interesting. And Fiona, sort of some related to this, you've talked about the need for coherence between health financing and wider economic policy. Can you share examples where health policy has either supported or undermined sort of broader economic goals when we think about industrial strategy, labor markets, productivity, some of these pieces that the panelists have already talked about?
Yeah. So I suppose I'd even maybe start just at a higher level before we get on to those examples and say, what do we stop and think about when we say a sustainable healthcare system? And the first thing is, I think our minds jump straight away to long-term care. We've heard a lot of that today, or long-term thinking, and then we go into preventative care. And that's absolutely correct. That's hugely important. But, this is healthcare, and short-term shocks will happen, regardless of what we do. And we, of course, know that after the last couple of years. So the first thing we have to start with is having short-term, medium-term, and long-term policies, which all run together and have a plan. So, for example, to go to a policy, if we're talking about, a supply shock in terms of medication, it's not enough to say in 20 years we're going to build domestic manufacturing in this country. You also have to have a plan for what you're going to do for the first 2 years, whether or not that's a budget that's a buffer, whether or not you're going to do pooled procurement with another European country, whether or not you're going to have a different type of contracting arrangement. So all of these need to run hand in hand. But then the next step is, I think we also haven't really talked about the fund. We've talked about how we purchase healthcare. We've talked a lot about that today. We haven't really talked about how we raise that, and how we raise funding is also going to be really important for the future. So if you look across, households in Europe, they've obviously had a particularly tough couple of years. The cost of living has increased. But a lot of these households are also faced with a rise in private health insurance and also with a rise in statutory health insurance. So even in a country like Germany, we know that they've had an increase over the last year. And what that means is that households don't have the same degree of disposable income in order to purchase their kind of general day-to-day goods, to spend on holidays, to spend on food. And so we're trying to raise money to say that we're going to pay for something in 20 years, but we're actually harming people today by not controlling how much we're taking off them. And so we know that their mental health will be impacted in 2 to 3 years, but also their physical health will be impacted in 10 years. So I think when we're thinking, how do we improve something for the future, we need to make sure that our actions today are not actually adding to some of that issue. And how we start by doing that in our work is to say, first of all, where's this country going when we go in and work with an individual country or, an individual region? And we say, every country is different in Europe. We talk about the fact that we're quite homogenous and we share a lot amongst each other. But what the needs of Albania are not the same as the needs of, say, Germany, of Belgium, of the Netherlands. And so we say, first of all, where is this country going? Where is their growth? What are the industries that they want in the future? And can we make sure that every policy that we look at today actually has a benefit in that in the future? And that's also sustainable, so that we know if they want to grow their life science industry, we haven't done something in the first 2 years that we're going to regret in the future. And that's the way I suppose we always take those approaches when we look at it.
Interesting.
Yeah.
Roland, I was hoping you can bring in the example of the Netherlands, and you've used national agreements to tackle some of the challenges like staff shortages, improving cooperation, and driving digitalization, which we've heard about already. What lessons can be drawn from that approach, and how do you balance competing pressures and the need for efficiency?
Yes, well, let me start. When you would, and I hope nobody does, but when you would develop a cancer, you're still very happy that you live in a country like the Netherlands where you be treated in the way you are treated over there. And sometimes people take that for granted because we have had that for a long time. And people do not always see the challenges that face our system, and which are definitely there. And those main challenges are, it's not even money. Of course, money is always important, but our main challenge is an aging society, staff shortages that come with that. And with aging society, we develop chronic diseases. We talked about prevention, which we do too little. But what we see, we have an aging society and we do not have enough people to take care of these aging societies. Today, we already spend 13% of our GDP on healthcare, and that will rise up to 20%. And like I said, money is very important because we need it for other issues as well. But we do not have the people anymore to provide that healthcare because we also need teachers. We need to invest a lot in our armies, for example, with everything that's going on within our police forces. So we do not have the people anymore to contain that. In 2040, we estimate that 1 in 4 people needs to work in healthcare in the Netherlands to keep the system going, and that might rise even further. So we put a cap on that. We say it cannot grow over 1 in 6, which is already an enormous amount, that 1 in 6 in this room should work in one way or the other in healthcare. So why do I say this? Because everything we do, all the changes we have in the Netherlands are based on having to curb that rising line of shortages in staff. So we came up with what we would call an integrated care model, which sounds spectacular, but which is actually putting everybody, all the organizations in healthcare in the Netherlands and the government and companies in a room and say, how are we going to do this collectively? And that was something new for the Netherlands because for those of you who followed a little bit the healthcare system developments in the Netherlands, you saw 20 years ago, we thought that we had found the egg of Columbus when we introduced market elements in the healthcare system. We thought that competition would solve it all. And well, we came back a little bit from that because competition is nice for efficiency, but it's not always good for cooperation. And we needed cooperation. So we put everybody in that room, the whole system in one room, we call that. And we started talking to each other. How can we make sure that we sustain the system with less people? And then I get to your question about examples. And we are in the beginning phase of that. But what we are doing, for example, is that we try to treat people as much as possible in their own homes. And then you get to telemedicine solutions, to e-health solutions. We try to limit the amount of time that people stay in hospitals as much as possible. And then you get to the social domain of things, because if you want to keep people as short as possible in hospitals, especially elderly people, what do you do when they are dismissed from hospital, where they go to? Because many of the times they cannot take care of themselves at home. So you need places between their own home and the hospital where they are, well, treated for a while in a less expensive and a less intensive form than we do at home, for example, or in the hospital, for example. So, well, I can talk a lot about this, and we are 5 on this stage. But so what we try to do in the Netherlands is that we try to reform the model in such a way that we tend to steer people from expensive, labor-intensive forms of care to less expensive and less labor-intense forms of care. And that sounds easy, and of course it's not that easy as I make it sound over here.
Certainly. I think underpinning some of this too is the need for data and better predictive tools. You mentioned staff shortages, that's one area, but solving some of these problems depends on that. So this is for the whole panel, anyone can pick this up, but talk to me a little bit about the use of data and how it can help governments and health systems plan more effectively when we think about driving a financially sustainable health system.
If I may, speaking about sustainability once again, about data, and of course, keeping in mind what just my colleagues from the Netherlands said. You know, first of all, sustainability requires at European Union level intergovernmental cooperation. Because the main challenge is fragmentation and a lot of unpredictabilities. You know, what we have now from United States administration, very important challenge. What is predictable? It's predictable unpredictability, because they decided last day to raise 100% tariffs on medicine. It immediately can affect sustainability in European Union, for sure. It means that we need to overcome fragmentation of 27 member states and understand that when we are speaking about healthcare system, they are so interconnected. Healthcare workforce shortages interconnections. Out of, shortages of medicines, interconnection. Possibilities to manage situation addressing, for example, cross-border healthcare threats, once again, interconnection. But in Lisbon Treaty, it's enshrined stupid situation that healthcare is member states' responsibility. No. Healthcare also is pan-European responsibility. And we need to think that we need to develop new managerial tools at EU level and also at member states level and see how can we overcome fragmentations, silo mentality, problems with interoperability, exchange of data. Otherwise, you have no chance to calculate sustainability. Starting with healthcare workforce planning. How can you plan healthcare workforce if you know that social dumping is going from one country to another? We need to know it, but never before, to raise questions. Now it's time once again, especially at EU level. I know that we are here in a country which decided to go out, but it's, from my point, it is a big mistake. That's just some spoke about pharmaceutical situation, clinical trials, for example. Clinical trials require what? Much more integration. Require pan-European ecosystem which can help us address a lot of issues. And now as never before, it's time to speak about much more efforts to addressing the challenges together, because otherwise you have no chance to use word sustainability in 5 years. I was Minister of Health, I was Commissioner for Health and Food Safety, I was Special Envoy, I spent 20 years. Sorry, but let's tell truth. We need now to say that interoperability and intercooperation and avoiding silo mentality is only one way in addressing those challenges which are around us. No one country alone have no chance to solve those problems. Maybe I am wrong. Please argue against.
Anybody?
I'd agree. I mean, the countries need to align. They need to work on this together. But your point earlier as well, Amanda, like the public and the private also have to work together. I think a lot of the creativity and solutions will need to come from partnerships between public and private, and a lot of the creativity and solutions need to be targeted at what are the real problems. Like, what are the real problems you mentioned is like, because of the aging population, we are going to have in Netherlands, as you said, 1 in 6 people having to work in healthcare. So if that is unsustainable, how do we fix that? And I think one of the ways is data. So tying that together, how can data solve that problem? Every time we go to the physician or doctor or anything, we're all giving our data. And our data is very valuable also to drive efficiency. So I'll throw something to you. In 10 years' time, do you guys need pathologists in Netherlands? That's a question. And if that is something that we could all determine, well, what is pathology? You're there and you are analyzing data and you're coming up with a determination, is this cancer, is this benign, is this malignant, etc. There are tools and there are technologies that these days are being developed in the private sector that are getting some funding that probably could do with more funding, that with the data and with a partnership with public institutions, they could probably accelerate. And those tools in the future, I do genuinely think, will replace the need for pathologists, maybe even radiologists, and a bunch of these functions, which then means those people shouldn't go away. Those people should be retrained to other functions of healthcare where they're needed, where we can't, through data, replace necessarily their workflow. I think the challenges we have is there's just huge inertia throughout the whole system. Everyone's self-interested. I'm sitting there as a pathologist. I don't want someone to come and, a technology to replace me and remove the need for me. But equally, that might not be what's best for the system. And I think a lot of the inertia we have in the system amongst all the stakeholders is what makes healthcare so slow moving, so slow to adopt technology, and so slow to drive efficiency and solve the problems that it has built in itself.
Sorry.
I was saying, the last thing, that's only solved through very active collaboration across governments, across public-private, to identify what are the 2-3 biggest problems and how do we get about solving this.
I might add to just the data perspective and taking the Netherlands back in, and sorry, you always get used as the example of how to do things. Mm-hmm. So it's probably pretty tricky to be in that position. But I think, we've spent again a lot of time talking about the fact that there are expensive medications and expensive treatments and how are we meant to fund them. But we never talk about the fact that there's so much low value care out there. And I know we talked about waste earlier on, but we didn't actually really quantify the care that should not be delivered anymore. And so there's around 20% of the Swiss healthcare budget is spent on care that should not be delivered. Probably the same in Germany. They say around 10%, but it's probably an underestimate. It's 2 to 3% in the Netherlands. And that's because you've been courageous, I think, in saying these are treatments that we do not do. It's not just a case of here's the new treatment and it's better. Instead, there's actually a list of do not do. But how data gets tied into that then is that we like to call it actionable intelligence, is the way we're kind of phrasing it. And we set up, what we think the program is going to look like, and we set up, whether or not a care should be defunded. And we're really fast to kind of say whether or not those indicators are going in the right direction. So it's not a case that you wait for 6 months or a year and you say, well, the program didn't really work the way we thought. Maybe that's okay. We've said at the beginning, this is what we should see. If we see this figure, we continue. If we see a different figure, we maybe give more funding. If we see a different figure, we just de-escalate and we withdraw. And I think if we're talking about something in 10 years' time, the risk, I suppose, of just funding it and being wrong in 10 years is too great. And so we follow the approach that the Netherlands has, is where we're like, these are treatments you should not be doing, and we will check up and follow up if people are doing that.
Yeah, and maybe taking that one step further, because we try to do that, like you said, and it's not always easy.
No.
But what we also try to introduce, and don't get me wrong, but we also try with an aging society, we try to start conversation by really all people in how far do you want treatments to go when you're 87 or 88. What's the quality of life there's some people still ride the bikes and other ones are just sitting back at home. So you need to have that conversation with people. What level of treatment fits somebody in that last couple of years of their life? Because some are happy to say, yes, give me that operation, give me a new kidney. And some say, well, do not bother. So we try to open up those kind of conversations also to limit overconsumption of care where that is not always the best choice. And that's very difficult because, he's talking about people's lives. But we try to open that venue as well.
Yeah, it's interesting. We need to get to the point where sort of incentives are aligned, but also we view innovation about what we will not do, and these, do not do lists that countries have, as equally important to introducing new shiny objects to the system, if you will. So really interesting. We have time for about 2 questions. Does anyone in the audience have a question? Panel, yes. A mic is coming, just a moment.
Thank you. So it's kind of going to the question about prevention and why aren't we doing enough verbatim. It's kind of like lip service, but it's not real movement. And I think it's about the structural changes. I'm not saying that we should be confirming a declinist narrative, but I think we do need to address the fact that there is increasing levels of deprivation in Western Europe, in our metropolitan cities. And not only are you getting an aging population, but based on class and race lines, we are getting a massive polarization. And instead of investing in communities and understanding that no one size fits all, we are now actively stopping that funding. Rather than going to consultancies, we need to be understanding who in communities, in our working, and I'll just say the word, working class communities, and our ethnic minority communities, not just in London, but in Paris, in Berlin, in Stockholm. This is a reality that we have to accept, that we have aging population, but we're also getting a new diaspora population, second, third generation, that are putting strains on the system. And instead of actually compounding populist narrative, we need to collaborate, pharma as well, because if people don't understand how to take medicines, asymptomatic conditions or whatever, then that doesn't help anybody. So it's about how we now engage public-private collaboration to actually look at policy of investing in communities. And I say that as someone who was brought up in a mining village in Derbyshire of South Asian heritage. So what I'm saying is there are intersectionalities of inequalities, but I'm afraid I'm not getting, I don't know whether or not we don't want to talk about it, but all I'm just saying is that we need people from these communities to help guide them in terms of building health literacy. So we have a polarization. And if we can actually address that gap, we will have a better society for it. And then we can actually have more of an incline and growth in our societies than this kind of narrative that, because technology is secondary to that primary community goal. If you don't know how to engage your communities, people are not going to be taking pharmaceuticals. People will not be taking advice. We have places in London where we have 18% breast cancer screening. This is a free system. So rather than stigmatizing communities, we need to work with them, not build separatism, but inclusive rainbow coalition where we can together lift as we climb. Otherwise, we are really going to have a lot of complex needs coming through. I mean, the likes of which you haven't seen yet. We're beginning to see this with low vaccinations, low screening, not just second, third generation immigrant communities. Now it's impacting through misinformation into our wider, more socially challenged, deprived communities of white origin across Europe. And I think the bourgeois have to now take action. If you don't take action, you can't just blame people for moving towards populists that basically are ready and eager to serve and manipulate.
Thank you very much for your comments. And it's a very important point. I'll come to you in just a second.
I couldn't agree more. Being commissioner has mantra, PPPP, prevention, promotion, protection of health, 3 Ps, not only prevention, but also participation. And it means we need to involve all communities. May you listen, may you know something about Sir Michael Marmot report and Michael Marmot cities, which are now established in Scotland, in 8 cities. It's about possibilities to address issues, social determinant issues, inequality, ethnical, all issues. And of course, we need to raise those questions now as never before. But you could agree with me that it requires not only investment in healthcare, because it's social investments, a lot of instruments. I argue always that prevention should be included into all other areas of politics, not only in healthcare. It means that prevention should be included and also in industrial activities, because you have no chance to address commercial determinants without inviting private sector to deal with it. Private-public partnership in prevention is a huge area where we can do much more. I couldn't agree more. I have no chance to oppose to you. Only we can raise those questions that we need to do, and we need to overcome mentalities as healthcare is only responsibility of healthcare politicians. No, it is responsibility of all of us. Health in all policies for all. That's old WHO doctrine. Who is against? No one.
Great. Yes, there's just to follow up. Thank you very much for that. There's an entire track tomorrow dedicated to Health for All, where we're going to be digging into these issues in a lot more detail. But I agree with you. It's incredibly important in the context of when we think about sustainability, that has to include everybody as well. We're over time. I'm getting the angry red clock. I'd love to take more questions, but if we can do so, if we can all make our way upstairs, there's now networking drinks and we can continue the conversation there. So thank you very much for joining us today. Thank you to our panel. Thank you very much.